Hey everybody, thank you for joining this another BANANAZ session. We have a number of exciting things to share today. It's a very open format if you're first time you're here. If you're not, you know. If you're first time, it's open format, questions, comments. Please share. There's the chat, unmute yourself and speak. Number of presentations. We are recording this. They're all, we keep recording, the recordings go on YouTube. So there's a YouTube channel for BANANAZ. If you haven't been there, just go YouTube BANANAZ, you'll find it. Okay, let's go ahead. I'll stop sharing, and Krishna, you're on. Please go ahead.
I just sent you a share request, Maxim.
Yeah, you should be good.
Okay. Can you guys see my screen?
Not yet.
Oh, here we go.
Yep.
Okay.
Yeah, we see that. It's not in presenter mode. It's
Yep.
yeah. Super.
Hey guys, I'm Krishna. I'm one of the neurointerventional radiologists at Goodman Campbell in Indianapolis. We were on our group chat, and a couple of cases of these Cribriform plate dural arteriovenous fistulas were being discussed. So I have two cases of these Cribriform plate dural arteriovenous fistula that were actually taken to surgery, and for certain reasons were unable to be cured. So let's just start with the first case. First one was a 6-year-old female who had these vague symptoms of nausea and dizziness for 3 years. She was actually told she had a meningioma at an outside hospital, and ultimately ended up coming to our institution where further vascular workup demonstrated this dural arteriovenous fistula that involved the anterior ethmoidal air cells. You can see these venous varices coming up through the floor of the anterior cranial fossa. I'm just going to point this one image out here. You can actually see 3 large varices that will come into play during the surgical resection. So we took her to angiography. Here's the right internal carotid run on AP and lateral. You can see these on the right side, at least, these anterior and posterior ethmoidal air cells extending through the medial orbital wall, extending into this dural arteriovenous fistula, confirming those 3 large venous varices. Here it is a little bit more prominent on the left side. Same thing, these ethmoidal air cells extending through with venous opacification with these varices extending through the floor of the anterior cranial fossa. So she was actually taken to surgery for surgical ligation, and the surgeon, as soon as he lifted up the left frontal lobe, he immediately identified these varices, and he was actually unable to get a clip at the floor of the anterior cranial fossa large enough to encompass all 3 varices. So what he ended up doing was actually he dissected completely around all of those varices. He took the more posterior varix and that giant varix in one clip, and that enabled him to get a little further down to the floor of the anterior cranial fossa and put a second clip as far down as he could at the floor where he could see this common egress extending into the floor of the anterior cranial fossa. Even with those 2 clips, extensive dissection around the floor of the anterior cranial fossa, he was not completely certain that he got all of the venous egress. So we did an angiogram. You can see that it looked, for the most part, resolved. As you guys know, these C-arms in the ORs are not, they don't have the best resolution. We did both internal carotid runs, and presumptively, we all came to the conclusion that this was at least the variceal portion certainly was occluded. But that, along with he microdopplered the dura, he microdopplered where the clips were, and there was no pulsatility. So again, presumed we were in an okay position. On post-op day 3, she had a little bit of mental status changes. Got a CT scan showing, a new intracranial hemorrhage right in the left frontal lobe. So took her back to angiography. And the carotid run does show the resolution of those varices, but there's still residual fistula here being fed by the left anterior ethmoidal air cells. So we're able to, do a Dyna CT scan. And as you'll see on the next case, these Dyna CTs are very, very helpful in elucidating the anatomy. So you can see that the ophthalmic artery is still dilated. You can see these arterial feeders extending through the medial orbital wall into this variceal enlargement within the ethmoidal air cells. And as you come up, you can actually see there's residual varix here, inferior to the level of the two clips. And here it is on coronal. You can actually see the varix coming out. There's a hyperdensity from where the extravasation is. You can actually see that it's inferior to the level of the most distal clip blade. So there's still varix here. But despite the fact that the venous outflow has been occluded, there's now just this empty blind venous pouch with arterial flow. Here are the MPR reconstructions. You can kind of see it better. Here's that venous pouch extending through the floor of the anterior cranial fossa. Here's the distalmost aspect of the clip, and this is the rupture site. So we were able to get into that left ophthalmic artery distal to the presumptive origins of those of the choroidal vessels. We were wedged. Here, this is just a Prowler 10. You can actually see the level of the fistula. You can see this blind ending venous pouch. So here we used a 4-to-1 glue. Here's the glue shot. We were wedged. We were able to, just slowly dribble glue anterogradely into that residual venous pouch and able to occlude the level of the fistula here. Here's our left run after the embolization. Here's our glue cast. On lateral, you can see that we were able to occlude this fistula here. And just for completion, here's the right side as well. You don't see any residual filling. Here's the second case, very similar. But this
We
patient,
discussed the first case.
sorry?
Let's discuss this case.
Oh, okay, sure.
All right. Are there any comments or questions? There's a lot to talk about.
Yeah.
Why don't you restart like from the get-go, from the initial angiographic images?
Sure.
So one thing, you showed us the ICA injection. Did you, by the way, put us also the external artery injections?
We did do those, but they weren't significant supply here. I just didn't show them for time purposes. But for the most part, these fistula were supplied mostly by the ethmoidals from both sides.
So, I mean, that's one comment I would make, that important that you obviously did, but like, often actually like the external carotid artery injection shows that there is a route. There is a route potentially from the often from the middle meningeal artery. And my feeling is that very often we can take care of this endovascular, which is I would say that's the main main approach I personally had in the last few years. I know that historically, like Cribriform fistula has been surgery, but like personally, I think that very often we can find a very good solution endovascular. So part of it is really like to see, even if there's a very small supply, you can really like wedge a microcatheter and potentially cure from the external carotid artery, like whatever middle meningeal artery supply. So that was my comment here.
Okay, so yeah, so I think the Eytan's comment is important in the sense that like sometimes there is a route from the external, which you investigated, that allows those that are not comfortable with catheterizing the ophthalmic, which can be discussed, but like and you could still reflux into the ophthalmic from the external injection, so it doesn't. But that's so that's one thing. Now let's keep going. Now you mentioned a number of times that like something about the Cribriform. I guess you meant that there is like posterior and inferior anterior and posterior ethmoid arteries supplying this, or you meant ethmoid air cells. I'm not so sure. about that?
I think the supply was coming mostly from these ethmoidal branches from both ophthalmic extending
Yes.
through into the
Yeah.
ethmoidal air cells. The level of the fistula, however, here, let me see if I can show it on the
The
dyne.
fistula is not in the ethmoid air cells. We have to be clear on that. The fistula is
Correct.
in the cranium. It, as obviously gets to be discovered surgically, it's an intracranial fistula. It's just above the cribriform plate.
Oh, yeah, exactly. Yeah. I think the difficulty in this case surgically was how deep the surgeon was able to get to the level of where the egress vein came intradurally. Despite the lifting of the frontal lobe, I think, again, I'm not a surgeon, but he wasn't able to get down deep enough to put that clip as
Yeah.
far down as possible.
Yeah, and I think surgically, and I'm sure he knew that's what had to be done, because just like when you do spinal dural fistulas and so forth, you really want to come down to the foot of the vein as much as you can. Now, if we look at the post-procedure images, I had a couple of comments. So first, I mean, you mentioned that there was a blind pouch. So I don't think the pouch is blind. If the pouch were blind, I think
You mean post-surgery, Max, right?
Post-surgery. If the pouch were blind, things would be different. I think there might have been drainage. There's still venous drainage kind of going down now into sort of like some ethmoid veins, like intranasal veins, like up into the superior kind of nasopharynx. If you look at the
On the post embo or post.
embo, maybe, I'm not sure, but it looked like it could be, and that's one place they can drain. Yeah, you see how there's like a shadow. Not post embo, post surgery.
Post surgery.
Embo post surgery.
Yeah, I mean, the concept is that if it was really like blind, right? I mean, it would have been a cure, right? And that's, like I agree on that concept. There has to be some sort of like outflow, otherwise it probably would have been a cure. What do you think, Krishna?
I don't know. I guess from an endovascular standpoint, as you had mentioned before, and I can show you on the next case, when we do dyna CTs and you see the level of the fistula itself, if you don't get down to the single hole of where the arteries converge to this venous head or to the true venous outflow, at least from an endovascular standpoint, that is never cured. So I think, in my opinion, the clip was too proximal. It didn't get down to the level of the fistula itself.
Yes, that's I agree on that. But what I like here, let's look at these images, right? Where is the contrast going, right? Like where is the contrast going eventually? Is that all rupture and extravasation, or it is indeed finding some outflow through some maybe very tiny venous outflow? That's what I mean. I agree with you on the other comment.
Yeah, where it's hard to say. I don't think that's extravasation just because of the chronology of the case. From my perspective, I thought, whether or not the egress is occluded and whether we can see that angiographically is difficult to say. But from what I can see is that, the clip wasn't distal enough and there's still arterial,
We agree on it.
arterial.
No, for sure, we
agree
agree
on
on it.
it, yeah.
But there is still egress. So one way you know there's egress is that you're able to inject glue. If there's no egress, how can the glue go? The glue is either going to go into like an extravasated space in the head, or it's going to go into some vascular space, and it's going into a vascular space. So I think what happens is the clip occludes a lot of the supply, but not all. There is still a vein that's not draining into the nose, or like in the ethmoid area. There's still some venous pouch that's very deep down intracranially. That thing ruptures. There's bleeding, and then you get to it from the artery. Now, I wanted to ask you the choice of a catheter. You mentioned Prowler 10 and your position. I agree your position is distal to the central retinal, but tell us about the Prowler versus, like, obviously it's a loaded question. Why Prowler?
Why Prowler? We've had this was a couple of years ago. We've had good experience with the Prowler 10 over a Traxxas. There's very little shelf with those. You can see the tortuosity of this ophthalmic artery, as opposed to a balloon microcatheter or.
Yeah, no, balloon, I agree. I wouldn't use a balloon here. My question is more, can you get more distal? Like, the choices to me would be headway duo, the 167 headway, or if you're going to use glue, then, obviously the Magique. I'm not, it worked. I'm not saying, like,
Yeah.
but I think, so one consideration is, and it's more important, I think it's more important to be wedged than to be,
Yeah.
like, I think you were wedged. So I think that's why it went so far. Just like sort of thoughts on.
I think, microcatheter selection. In the next case, we had a lot more difficulty with our microcatheter, but in this situation, we wanted to get as little shelf as possible. The Prowler 10 over a 14 wire was, easily able to get where we wanted to. I didn't show it. We actually had another vessel that we interrogated with a microcatheter that we didn't feel that was wedged. For the purposes of this, I just showed the ultimate resting position of our final catheter position. But I agree, in a wedge position with the diluted glue concentration, I think being wedged is the most important thing here to avoid reflux, especially in absence of a balloon microcatheter like a Scepter Mini, which I think at the time of this case we weren't even using.
And it can be hard. You commit to a scepter, it may be hard to pull a scepter. It's not so straightforward. We prefer doing these as you did. You go as distal as you can with a regular microcatheter and just go for it. Leanne had some comments on the chat. If you're looking at, open the chat, everyone, if you don't have that open. So I think they had some questions, like some of it we discussed, Leanne, about the pouch. Now there was also a question about a transvenous approach, right, Leanne? You were asking if a transvenous approach could have been tried.
I can talk to you more about that in the next case. Actually, we didn't see a really good venous route here on the Dyna CT. And actually, in most of our fistula cases, we try to go transvenously. And for whatever reason, we didn't see as I said before, the varices were occluded surgically. We didn't really see a venous route into the level of the fistula itself. So at this point, just given the fact that she had hemorrhaged, we went transarterially.
Sure. So after surgery, I think that's it. But before surgery, did it come to you before surgery? Like, what were the options before the surgery?
This case did not come, this case, because there was no good venous route, the decision was made to take her to surgery initially.
Initially, there was no good venous route. Yeah. And
for referral patterns and the misdiagnosis of the meningioma for multiple reasons, it was taken to surgery as first choice.
Now, was a Dyna CT done at presentation or only after surgery?
No, only after surgery. That is not our normal course. And again, I can show you on the next course. In most of these fistula cases, we do a Dyna CT for multiple reasons, to evaluate the anatomy, to actually evaluate a proper venous route. In this situation, the Dyna CT was only done after the hemorrhage.
Yeah, so that's also a comment I would make. You emphasize the importance of this. Sometimes even if I would say, even if the plan is for surgery and so forth, sometimes just doing it gives you enough information that, you may, for example, in this case, it may have been like if the surgeon really saw how deep into that bone groove the fistula was, maybe the approach would have been different surgically, even, I would say. So and I know we agree on that. I'm just, I just wanted to emphasize that point.
That's next case, right?
Yeah, the next case is very complementary to this, and then we can kind of discuss further. So this is a 77-year-old presenting with the subdural and subarachnoid hemorrhage on presentation. At the time of the surgery, the patient had a vascular workup actually showing, demonstrating very similar dural arteriovenous fistula. This is the left side. Very similar to the other case. There's a dural arteriovenous fistula supplied, but mostly the ethmoidal branches off the left internal carotid artery, ophthalmic artery. Here's the left ECA run. Not much supply on this left side from the middle meningeal. Just for purposes, supplied bilaterally by these ethmoidal branches off the left and the right side. So here in this situation, we did do a Dyna CT before the subdural hemorrhage was evacuated by the surgeon on call. And ultimately, the plan was to take for further surgical ligation. But here, you can see the Dyna CT that was done before any surgical intervention. So you can see this enlarged and dilated ophthalmic artery with these ethmoidal branches extending through the medial orbital wall. And you really get a better sense of the anatomy of these fistulae. Again, I don't need to tell you guys, but you can see the level of the admixing of the arterial and venous opacification. And interestingly enough, we do these Dyna CTs not only to better elucidate the anatomy, but also to evaluate the venous route. So interestingly enough, you can see the admixing of the arterial and venous opacification. And fascinatingly enough, on these Dyna CTs, you can actually see flow voids or non-opacification, in this case, from unopacified flow coming from the additional arterial feeders. In this situation, we know that there's feeders coming from the right side as well. So you can actually see the level of the fistula, the admixing of the arterial and venous enhancement to the point where you can see the level of the fistula. And again, it just gives you a better sense of the anatomy. And the second reason why we love doing these Dyna CTs is it really gives you a better sense of a possible venous route. So in this situation, there is one venous egress at the floor of the anterior cranial fossa that comes up, and there's some variceal tortuosity, but you can follow this vein all the way up this pial vein as it empties into the sinus itself. And for these reasons, we love these Dyna CTs because, again, if you're evaluating for a transvenous route, the way that we like to do these cases is actually getting 2 microcatheters down into this venous outflow, again, to the level of the fistula itself. And 2 microcatheters we typically try to put at the venous head. 1 microcatheter will try to coil until we get kicked out, and then you're left with this second microcatheter that you can onyx behind it. And a lot of times in these situations, this tends to be the most difficult, or one of the most difficult parts of these cases. You can see that the dumping of the sinus into this pial vein can sometimes be a very low caliber, almost like a sheet of vessel. And trying to get 2 microcatheters, let alone an intermediate catheter across this transition can be very challenging. Even getting 1 microcatheter across this transition can be very challenging. So we didn't really think that there was a good venous route into this fistula. Here's the iterative reconstruction. This is a Siemens 14-second microdyna CT with the volume reconstruction. You can actually see the level of the fistula itself down through the ethmoidal air cells, cut away with clip planes. And again, this just allows you to see the anatomy in a much more detailed sense, the level of the fistula itself. So for the reason being, we didn't really see that there was a good venous route here. Again, prospectively catheterizing the ophthalmic artery can be challenging and risky for multiple reasons. So again, this patient was taken to the OR for surgical ligation, and very similar, actually it was the same surgeon. Once he retracted that left frontal lobe, he immediately saw this egress, the egress single draining vein. He was able to get down to the level of the anterior cranial fossa, put a single clip across it. Even with that, he was not entirely sure that he was able to occlude the vessel, so we did an intraoperative angiogram. And you can actually see here that there is still fistula present, but that venous outflow was occluded. There's still fistula there, but same thing, he Dopplered the dura, Dopplered the level of where he positioned the clip, which was all negative. And at this point, again, whether or not this was the right decision, at this point we determined that it was at least decent enough at the time. That very night, patient had some mental status changes, and you can again see that there's a hemorrhage at the floor of the cranial, the anterior cranial fossa. So took this patient back to angiography. You can see here, relative to the C-arm angiogram, much more obvious. The level of the fistula is still there. That variceal egress has been occluded, but there's certainly still fistula at that level. This case was much more difficult to get into the ophthalmic artery. We tried multiple combinations of microwires, microcatheters. We tried to inflate a hyperglide balloon to try to get the microcatheter into the ophthalmic artery. We were finally able to use a triaxial system with a J-shaped prowler, and was able to finally get into that ophthalmic artery. Here's the ophthalmic artery run. You can see that there's still fistula and venous outflow at this level. At this point, we decided to proceed with glue. I don't have a picture of the glue shot, but we used a much more diluted concentration of 6:1. And you can actually see the glue cast here at the level of the fistula. Here's our left internal carotid run after the embolization. The entire ophthalmic artery is occluded at this point. Interestingly enough, the patient didn't wake up with any visual symptomatology. But this case, again, very, very interestingly enough, and somewhat similar to the first case, the level of the clip, in my initial opinion, is just not to the level of where it has to be. It's not at the level of the admixing of the arterial and venous opacification of where the fistula actually is, which in my opinion is right, or was right there, where you can see this dumping of all of the arterial enhancement. And so if the clip is placed, again, if the clip is placed too proximally, then there will always be a residual fistula, and might lead to, persistent, arterial pressure in this, venous pouch.
And I wanted to say something. Let me say it, because it may not sound right if you say it. You have amazing surgeons there. We're talking about world-class surgeons, right? So when an interesting thing when I look at this is it's I would say this is a limitation of the surgery and not of the surgeon, based on what I know about your team.
Well, thank you, Eytan. Yeah, absolutely. Our entire surgery team, this surgeon in particular, has 30 years of, dedicated cerebrovascular experience. But again, we're here to, again, talk about the pathology. Again, we didn't feel that there was a good venous route into this. If we had, again, if we were able to get past this, assuming we were able to get past this transition of the pial vein into this sinus and get a microcatheter down, in my opinion, the microcatheter, the two microcatheters have to at least get to this level right here, to coil once you get kicked out, to onyx behind you. But again, reaching this surgically, in my estimation, is very, very challenging to get down that deep, that far.
Super interesting case. There's a couple of comments on the chat. Keisuke is saying there was a posterior drainage through olfactory vein, maybe pre-surgically. Like sometimes there are several veins draining it. You could see there's like also a lateral frontal vein there. If you review this again.
Let me see.
If I can I say something?
Of course, please. You don't have to ask. Just say.
Okay, thank you. Couple of things. Of course, the surgeon sees the vein once it comes out of the dura. So it cannot go really deep the way you would like it to see, because that's outside the dura. The vein, before coming subdural, intradural, has a little, centimeter or so, which is covered by the dura, so the surgeon doesn't see it. So maybe he was really at the limit of what he could see from intradural. Of course, we would need the surgical images. Second thing, can I see the CT scan of the hemorrhage again?
Sure.
It didn't look really like the hemorrhage came from the fistula. No, sorry. The post-surgical.
Post.
And also in the first case, I was not so sure. So I'm asking if there is the possibility that this hemorrhage, it doesn't look like it comes from the ethmoidal, no?
These are six slabs, right? But like the hemorrhage is not centered at the bottom.
Exactly. So it looks more like a venous hemorrhage. And also the first one, it looked to me in the other case. So I'm not so sure there was there was a remnant of the fistula.
No, but sorry, but hemorrhages from fistulas are venous, right? It's a like, now.
No, I mean thrombosed veins, occluded veins, not ruptured veins. So this looks like a transformation of an ischemic venous
A
problem.
hemorrhagic infarct, like a venous infarct. That's what you mean.
Post-op venous stroke.
At least looking at this, can you go a little bit further down to see where it comes from? It doesn't really. Yeah. So if it were the fistula, the remnant of the fistula, you would expect it to be really close to the bone, no? Because that's where it was. So the point is, maybe it's a different problem. Maybe it's a problem connected to venous thrombosis, which is something that we see in the treatment of dural AV fistulas, and we see the complications, also endovascular complications of thrombosed veins that gives you hemorrhagic problems after the perfect occlusion of the fistula. So no, it was just a comment on a different perspective of the same problem. I'm not so sure that the surgeon has to go inside the bone, of course, to clip the vein. I'm sure he cannot, because he sees the vein a little bit after its origin from the fistula, and so he does what he can, but and it usually works. Okay, that was my comment.
There's a couple of good comments also on the chat. So you get asking, there's a pre-op Dyna CT, there's a previous craniotomy. Do we know what it looked like there was a sort of bony defect there?
Yeah, so the patient was initially taken on call for evacuation of the subdural, and then was retaken for surgical ligation. That's why there's a bony defect on the initial.
Okay. All right. Leanne saying that there could be a hybrid procedure where the surgeon gives access to the vein and then we can retrogradely, intraoperatively. We've certainly done that for sure. That's a great idea. We've done that for sure for other, like in several occasions for different reasons where that made sense. That would probably require a hybrid OR. I mean, you could try to swing it with a C-arm but that probably wouldn't be ideal. What do you think about that, Krishna? Like, is that something to consider?
Yeah, I mean, there's certainly, for CC fistulas and, venous access to get down to the level of the fistula, for sure. I mean, I think the access to this vein surgically, I don't know if I can speak intelligently about that, but certainly, again, that's why we love these transvenous the transvenous approach to these. Getting to the level of the fistula itself here, I mean, just off the offset would involve a lot of tortuosity getting down to this venous head. I don't know. I don't know how.
The idea of like puncturing this with an angiocath or something, tying it off, and then you retrogradely inject onyx or glue. I think it's something that we have used, and it's a very it's an option that probably is like underutilized.
One thing that I was thinking, and again, we had discussed this in our own, I believe in our own M&M conferences, when these cases are taken to surgery, and regardless of what the C-arm angiography shows, that's very limited in resolution, regardless of what the microdoppler shows, lack of pulsatility. If there is some question of residual fistula there, would the appropriate next step would have been to just take that patient straight to angiography at that point and finish the occlusion in an antegrade fashion. Again, that's difficult to know, especially when you're catheterizing the ophthalmic artery and potentially unnecessarily. I don't know. I don't know if anyone thinks that would have been a reasonable next step, given the findings on the intraoperative angio. Is that what anyone?
No, retrospective. I mean, retrospectoscope's 2020, but I think it depends on how. It's really about what is your assessment of the intraoperative angiography.
Yeah.
Really about the confidence of that. If you're confident that there is a residual fistula, then something has to be done. Like I think that's if it looks better but it's not closed, right? It's not like this. It's either closed or it's not.
Yeah.
So if it's not closed, then I think doing more surgery or doing something like would be typically our approach. Like if we have an AVM that's left after surgery, if we're not doing it in a hybrid room, we go back and obviously try to finish it. But speaking of the ophthalmic artery, it's interesting. The other thing that's interesting in this case is obviously there's a lot of difficulty because of how the ophthalmic comes off, right? Like the angle doesn't look great. You have difficulty in catheterization, which should be acknowledged. Like we push for treatments transophthalmic, but look, it can be difficult in experienced hands. And in the end, you lose the ophthalmic artery, right? I assume to thrombosis or to dissection or to something, right? Yet the patient maintains vision, right? You said that vision was not lost. I have a similar case. I had a case where years ago I glued the ophthalmic arteries and like completely angiographically, yet the vision is spared. So, better lucky than good for me for sure. But that's another thing. I think we should acknowledge that that's a possibility. Do you have any more insight into what happened to the ophthalmic?
I mean, no, in terms of why the patient maintained vision.
In terms of why it was lost.
I think our glue shot in this situation was probably, again, I don't have the glue shot or the glue shot itself, but the cast itself looks pretty distal here.
Yes.
A combination of thrombus and lack of antegrade flow post hemorrhage.
Well, it's not going to be post hemorrhage. Like post hemorrhage, the ophthalmic was alive.
Yeah.
Do you have a common? Because it could be that by then it was occlusive, so there was retrograde flow from the external.
I think I have on this presentation. I don't. But
that's not that was you ruled that out.
Yeah. No, I don't have any other comments on the ophthalmic of why we don't see it here. We manipulated it quite a bit. However, again, getting into that ophthalmic artery was quite challenging with a combination of multiple microcatheters and techniques. Maybe a little spasm on top of that. I'm not entirely sure.
I think, I agree. Like it's either going back to surgery or going through the ophthalmic. These are the options, right? So I would have chosen the same option to do through the ophthalmic. But as you know, we push for that. We love this route for these fistulas, but it's the risk should be acknowledged.
And anyone comment, either in the audience or you guys, about transvenous approaches for these types of fistulae? Have you had cases where you've been
We've
able to
done
get
it.
that?
We've done it. It's usually not straightforward because the vein is very tortuous there. And I think there is a report of a death from this approach in JNIS. It's a video report. And I think that to me that's scary enough to keep it obviously as an option, but be mindful about that because like with the ophthalmic approach, okay, we've never had an issue with the vision, but theoretically, obviously, you cannot argue against that theoretical possibilities, right? So I think it's obviously something to consider, but to me, just seeing that very scary case to me is like gives me some
Pause.
consideration when I think about it. There's someone here in the chat who said they've done 4 cases. I don't know if they want to comment about them. They can they can open your microphone. Going back to the ophthalmic approach, sure, there is a theoretical risk, but we like we go to very critical vessels as a daily routine. Like we do that every day we are always in very critical vessels. So why it is almost to me like it's almost like a cultural barrier we have for this. I have to say, obviously we have to be extremely careful. And will there be a complication? Yes, as much as there, of course there will be. Dodi, what do you think about it? I know you're absolutely pro surgery for this, but here we are. You showed like two like potential like catastrophe from surgery, right? Like let's consider that as well when we think generically about the approach.
Absolutely. But I just wanted to say that I disagree with the fact of the ophthalmic approach. And I think that, yes, some people can do it, but I wouldn't want that here we pass the message that, well, the ophthalmic, yes, even if it works, if it doesn't work, you can get the vision later, or it stays even if you occlude the artery. No, please, no. If there is a different solution, of course, if there is no other solution, but there is usually a different solution, because maybe the complication happens once in 50 cases, but that's too much because you lose one eye, and that's too much in the life of a person. Maybe even worse than losing, one leg. And so I am not sure we should say that the ophthalmic approach is something that you can, well, easily do, or yes, there is a risk, but everything we do has a risk. There is a risk and a different risk, especially if you have a different approach and a different possibility. One is the external carotid artery, and that I completely agree with you, that you often have a possibility to get there through the external. 2 is the venous approach, and for that, probably one of our first cases of occlusion of a dural AV fistula through the venous approach was some 30 years ago in the 95, 96. We did an ethmoidal case but of course it was a straight vein. Yes, if the vein is tortuous, then you risk, and people have killed the patients by doing that. So yes, and then there is surgery, and surgery usually is the simplest thing to do. So I don't know why these 2 cases, and I thank Krishna for showing them, had this unfortunate outcome, because and I still think it was not the fistula. It was probably, you see the vein in this image, you see the vein draining the fistula on the 3D reconstruction. Yeah, you see the vein there, and maybe the surgeon in some way occluded the outflow of that big vein, which was a hemispheric vein, and that gave the hemorrhagic transformation of a venous thrombosis. But anyway, so no, I just wanted to say, please take care when you think of going through the ophthalmic artery. Even one case out of 50 is too many, is one too many.
Maxim, I had one question because something that you said in the first case, the fistula itself is intracranial. In this situation, again, this is obviously a very different case than the first one, but the images which suggest that the level of the fistula is actually within the ethmoidal air cells. The pial draining vein is intracranial. Where that vein enters the dura is intracranial. But I mean, just for semantics, is the fistula itself here truly intracranial? The level of the hole.
No, it's a great question.
As far as I'm interpreting this angiography, especially this one image right here.
Yeah.
The level of the fistula, the level of the hole, which, as we most know, these fistulas are usually, it's one hole. The hole itself is in the ethmoidal air cells, from what I can see here.
Yeah, I guess in the interest of time, we could probably discuss later. But no, it's a great question. I think that's a key question. Like it's more than semantics, as you said, because really, the theory, and I think the guiding principle is that we need to close the hole. So we close the foot of the vein. So the whole question is like, where is that hole? So I think it's a very important question. For sure, like certainly I'd say that, if we eliminate any access of whatever the fistula component is to the intracranial compartment, we eliminate the risk of hemorrhage, which basically is at the foot of that vein. It's just getting to that vein is difficult. So maybe we can talk later about like that, because I think it's a lot of detail. Boris by the way, has a link that he sent to the chat with a transvenous series. And speaking of which, so Krishna, thank you so much. These awesome cases, like long discussion, right? Like we spent a lot of time on these two cases, but that's the heart of Bananas, is like case-based learning. It's tons of stuff that's so important. So Boris, you're up next. Thank you for waiting. Go ahead.
Okay. Hi guys, thanks for the invitation, Eytan, Max, Krishna, Chris. Really great presentation. My topic today probably is less challenging than the previous one, that the complex fistulas. For today, I will talk about wide neck bifurcation aneurysm. Probably everyone has the same question in the attendees. What is the optimal treatment for this condition? And the best answer, unfortunately, is nobody knows what is the optimal and the best treatment. Over the past 2 decades, a variety of tools and different approaches have been used. And more recently, the intrasaccular approaches have triggered our interest in the field. Here is an illustration of the different intrasaccular technologies, but today I will only focus on the new Seal Galaxy device. The new Seal Galaxy device is a dual layer, a Retinal device. It's DFT technology. The device comes in 2 different configurations, the arc and the vase. Okay, here is the typical illustration of the basilar tip, the typical scenario where you may see here a base device. You may see here the conformability of the device and at the median of your screen. And here is the final result. How looks the device in the low contrast image? Look the conformability around the aneurysm. Really good conformability. And here the second one, the arc configuration. This is 15 millimeters in the weight. The device included a mesh loop at the top and a dual layer, of course, at the bottom of the device. And here is how you may see the device under fluoroscopy and at the low contrast image. Here is the size chart of this technology. You may see here the device range between 3mm device until 20mm device. The smallest sizes would be delivered using 017 microcatheter technology. And of course, devices greater than 12 demands or requires the via 33 microcatheters. What's the plan for today? As our previous conversation with Max, the idea is to focus on the follow-up, especially patients with 1 year follow-up. And I would like to share with you a couple of very illustrative cases with 3 years follow-up. This is a right MCA and raptor aneurysm. You may see here how looks the device during the navigation. The radiopacity is really good. You may see here. And here is how looks the device once deployment. Here is the device. And the detachment system is very similar than other intrasaccular technologies. It's electrolytically. This is the immediate angiographic result, the first day. And here is the 1 year follow-up, where you may see here a complete obliteration of the aneurysm, and the aneurysm is gone. This is another working projection. This is another illustrative case, left MCA. Here we use a base device. This patient was under dual antiplatelet therapy because the patient was treated in the right side with a Stenny coils technique. You may see here the contrast stagnation inside the device. Here is the contralateral, the laser. You may see here the Elvis in the right side, and you may see here how looks the device. And 1 year later, you may see here in the native, the device remains very stable, and you may see here the 3D angiogram, the aneurysm is gone, and we classify the final angiographic result as a web occlusion scale grade A. This is another 1 year follow-up. This is a left MCA. You may see here the run in comparison with another intrasaccular technology, especially with the web. You can observe the proximal recess. You definitely may evidence a complete obliteration at the level of the neck. And here is a couple of very long-term follow-up. This is a anterior communicating artery aneurysm, filling through the left side. Here is the size of the aneurysm. Here during the sizing of the device sizing, you may see here the navigability of the device. How looks the device on the fluoroscopy? Good visibility. This is immediately after deployment. And here you may see here how it looks, all the contrast stagnation into the device, sorry. And you may see here the conformability at the level of the neck. Here is 1 year follow-up. The neck was completely remodeling, yeah. And you may see here in the DSA injection, nothing inside the aneurysm. It's a complete obliteration. This is the initial 3D reconstruction. This is the 1 year follow-up control. This is the frontal view 1 year. And the patient, unfortunately, is reluctant to go to the angio suite, and we decide to follow using a MRI. And you may see here the aneurysm, the treatment remains stable. This is the lateral view in the MRI. You may see here, and in the MIP, you may see here, we can observe the aneurysm filling through the anterior cerebral arteries. This is a great case. This is a bleeding case where we initially decided to use this technology. It was a very early stage in our experience. It was a left MCA aneurysm, trilobulated. As you may see here, it's a very ugly aneurysm, multilobulated. As you may see here, all the components of this aneurysm. And here the initial rotational angiography. And here during the selective catheterization, just to identify what would be the plan. The idea, similar than other intrasaccular technology, the idea is to focus at the core of the aneurysm. We may ignore all this kind of secondary lobes. Yeah, the idea is focus at the level of the neck, at the core of the aneurysm. And here you may see here this is immediate angiographic result. Obviously, it was a bleeding case. The patient wasn't under any antiplatelet. Probably you may get a really good immediate angiographic result like this. And here is 1 year after procedure. You may see here how looks the device after 1 year. The aneurysm remain completely closed. And here is 3 years follow-up. We only may see here the radiopaque marker at the bifurcation, but the aneurysm is gone. And here how looks the 3 years later, the device. You may see here the rotational and the 3D reconstruction. One more time, how looks the 3 years after procedure, the low contrast image in a different projections. And just to highlight in this slide, how has been the shape of the shape and stability of the device. This is immediate. I look at the microcatheter here. It was exactly at the delivery during the delivery phase. Here is how looks the device 1 year later, and 3 years later. We may identify some reduction in the device height, probably same condition that we observe with the web, when both radiopaque markers try to get close. In this particular scenario, the height of the device was significantly reduced, but the final result, as you may see here, is really good after 3 years of follow-up, as you may see here. This is the same projection in the initial rotational at the 3D, and here the final angiographic result 3 years later. And just to illustrate you a couple of a case in the SEAL trial in the US, because the experience in the US have reached 6 months, and probably during the next semester we will check all the follow-up of all the patients treated in the SEAL trial. This is one of the cases in a sidewall aneurysm with a really good result 6 months later. And just to finish, the question regarding the intrasaccular technologies is what would be the best approach. And unfortunately, even with these impressive results, probably nobody knows. Most of them have pros and cons. Each device should be used in the perfect condition, the perfect anatomy, the perfect candidate, and obviously everything depends on your experience. Most of time, most of our approaches are based on our beliefs more than the science, and we are facing permanently this this balance, yeah, what is your beliefs and what is the science. Unfortunately, we are in the middle of a very, very critical race regarding the medical devices and the clinical trials, and we observe a lot of bias, the absence of RCTs comparing one technology against the another technology, and probably the idea is to build your own experience. Some final food for thought. In all our endovascular approaching, unfortunately, we don't have a specific device to fit it all. Nowadays, the brokers and traders are really common. The idea is visualize your own graph, especially these two major graphs, your learning curve and the Dunning-Kruger effect. Yeah, the idea is to identify your competence, your experience, your knowledge with each device, trying to select the perfect device for the perfect anatomy for the perfect patient. The idea is to ask you where you are definitely. One of my major advice in terms of intrasaccular technologies is the difference is completely dependent on the obsessive attention for the details. You have to check how looks your branches, how look the device, how look the shape, take different measurements, and not just sitting in front of the screen. This is Professor Moret visit us in Medellin, Colombia, and you may see here people with a vast experience dedicated to check every measurement in order to get the perfect device. So here is essential the perfect balance regarding the clinical condition of this aneurysm, the location, how looks your access, your entry angle, if necessary to pre-shape or not the microcatheter, how looks the morphology of the aneurysm, if you are dealing with a classic wide neck bifurcation aneurysm, or if you are considering to treat some sidewall highly selected aneurysm. Obviously, the aneurysm size is critical. Most of the technologies, you have a restriction or limitation if you are dealing with aneurysm at the borderline zone, aneurysm between 9 to 10 millimeters. With this new technology, you have the possibility to treat condition until 20 millimeters. But the idea is to check all your stock, your tools availability, and of course, all the previous one with a great basis, and thanks to your knowledge and experience, trying to move this imbalance not to your beliefs, but more to the science. For the reason, it's more necessary to check the trial results. We are waiting for the US trial just to check the experience. We have had early experience with the first in humans, but we really need to confirm if this data is real is true in the real world or not. Regarding the device sizing, many times you don't have the technology or you don't have the software to do that. But the classical approach using your different measurements in different projections works really good. Take the time to do that. But probably with the intrasaccular technology in the near future, a customary sizing would be necessary. Similar than other intrasaccular technology, the device compression is essential, probably less than the web. The web demands or requires greater than 1 point if you really want to get a great long-term outcome. But with this technology, we have evidence only 0.5 millimeters in oversize would be enough. Just to finish, you have to compare intrasaccular against intrasaccular. The idea is to compare the impressive result with the flow diverted technology with this different kind of technology. There are completely different approaches. And just remember, many times you will be here and the intrasaccular technology will be your real life best in an emergency condition. Thank you so much. And if any question, because
Boris, thanks so much.
yeah.
Okay, any questions, comments? Krishna had some on the chat about lateral compression, less lateral compression versus web. Can you talk about that?
No, we consider that probably the fact that you have especially for the R configuration, if you have the loop, probably at the interior of the aneurysm, you may evidence less compaction, a less chance to migration of the device, and probably you create different compartments at each side of the mesh loop, and probably with a minimal oversize would be enough. But it's just our early appreciation. It's not a scientific demonstration yet. Probably according to the US results and the global registry, the patients are ongoing and the enrollment are ongoing, we will establish how critical would be the oversizing. But when we try to use exaggerate oversizing, immediately we evidence a device deformation because the device is a little bit softer in comparison with the web, for example. And if you oversize in extreme, the device folding, and you may obtain a misconfiguration, and probably you are in the worst scenario. For this reason, it's preferable to focus at the level of the neck, and you may ignore it even until 3 millimeters of the fundus of the aneurysm. For the reason we believe that the oversizing in this particular device is not critical as the web.
Okay, so again, attention to detail, right? Different detail is the attention to detail continues. But now for measurements, okay, there was also a question about sticky detachment compared to the web. How's the detachment?
Okay. Fortunately, we are working nowadays with the 4th generation device, and the detachment system has demonstrated 100% of the detachment after the first attempt. Yeah, during the early stages, obviously, as breakthrough technology, the initial generation many times was necessary to use different handles, 2, 3, 4 attempts. But during the last 1 year, you may see the detach at the first attempt 100% of times.
How many cases have been done worldwide? Do you know?
Okay, in the registry, close to 60, and the worldwide registry, yeah. The first in human were 33. And the US trial is close to 250. So in general, over 300 cases worldwide.
It's impressive.
How many intraoperative rupture have you had?
No. It's, the safety profile has evidence a really high safety profile, even in bleeding conditions. And I heard only one, obviously is part of the information of the US trial, but just one adverse event related with that. Yeah, just one. One. Yeah, but not directly with the device, but also but was with the microcatheterization. Yeah.
Now you mentioned
But
device.
the good point here, you don't The initial portion of the device, obviously you don't have the distal radiopaque marker. You only have, or if you are using the ARC device, you have a loop, yeah, completely soft, yeah. Or if you are the base, both devices are really soft in the initial portion, yeah. Probably many times you may push the device instead to unsheath the device. Obviously, depend of the how loose your aneurysm and how loose the height of the aneurysm. Yeah. But in terms of safety, as a web user, obviously with this device, you are a little bit more confident to start the delivery process in comparison with the web. Yeah, it's one of my personal insights. Yeah, because the feeling when you are delivering this device is not like a stent, not like a coil. It's in between. Yeah, I'm not sure if you have experience with the Alvis Evo. You may feel something similar. It's the same level of friction.
Okay, Vittorio has a question.
Hello, everybody. Thank you. We actually two questions in very impressive cases. Thank you very much. So the first question is, do you have a dedicated microcatheter, or you have you can use whatever catheter, because the VIA is, for example, you mentioned is not so good, so you can use other microcatheters. And the second question is, you've seen beautiful cases, but around these 350 cases, you have any idea of the recurrences, because it's the main problem with these devices? So maybe it's better compared to the web, or you have any idea of the recurrences, or it's something like the web? Okay.
The first one regarding the microcatheter technology, you may use any kind of microcatheter until 27. Obviously, for devices greater than 12, it's mandatory to use the BA 33. Yeah, but you may use in terms of 21, 27, you may use any kind of microcatheter where you are familiar with. Yeah, if you prefer the Phenom family, Headway, yeah, and whenever you want. Yeah, and the point to highlight here is, I recommend to steam the catheter and pre-shape most of time. Yeah, only for the classical basilar tip aneurysm, I prefer to maintain the microcatheter completely straight. But for the rest of the cases, I recommend you to steam and pre-shape the microcatheter. And for the smallest devices, for the 017 profile, the company recommend to use the BA 17 microcatheter. Yeah. Otherwise, you may feel too much friction. Yeah, too much friction to advance the microcatheter. Sorry, to advance the device. And curiously, there are a lot of users recommending the Prowler technology. It's an old technology, yeah. But they have feel a really good stability, good navigability. But we don't have these microcatheters in Colombia, so probably you may use any kind of microcatheter. And regarding your second question for the recurrence rate, obviously in our personal experience, the obliteration rate surpass 80% of complete occlusion, no? Complete, not adequate. Complete occlusion reached 87% of the cases. And until now, we don't have any experience with retreatment. Yeah. In the US trial, few months ago, we made one of the initial interim analysis, and no retreatments observed at most during that time. Yeah. But as I mentioned before, just in the trial start in September, and we are waiting for the more and more follow-ups, yeah, especially 1 year follow-up. And in the US trial, there are 3 groups: the classic wide neck bifurcation aneurysm, bleeding cases, and sidewall aneurysm. And probably we are very attentive to the bleeding condition, because many times for bleeding condition, the aneurysm looks a little bit smaller than in the real size. And we really want to check how is the performance of the device in that scenario. But the recurrence and retreatment rates in our experience is 0 at that moment.
Okay. Boris, thank you. There's another question from Krishna about antiplatelets.
Okay. One thing is, the company and the US trial recommend to use a dual antiplatelet therapy at least 3 days before the treatment, yeah, obviously for unruptured aneurysm, the classical dual antiplatelet protocol. In our early experience, close to 50% of the cases, in close to 50% of the case, we don't use any antiplatelets, yeah. But it was part of our experience, yeah. But in the rest of the world, in the US, the company recommend to use a dual antiplatelets. Go for the procedure. If everything looks really good, you may stop it. Or if any consideration, any protrusion, the idea is to maintain the dual antiplatelet for almost 4 weeks. Yeah. But obviously in a bleeding condition similar than web, this is a really good approach. If you have the perfect size, you may use it, because remember, this is a dual layer, and the metal mesh density at the bottom, obviously depending on the size of the device, but may reach 85% of metal coverage. Yeah, it's a really high metal coverage.
Any other questions?
Yeah. Now we know for the web, the problem with the cases you show with the follow-up, all good, obviously. I mean, I assume these were good ones, right? That you show us, and very good. And I'm sure like that is reflective of overall the experience, but most of them were small, right? Other than the ACOM aneurysm, most of the aneurysm you showed were small. Now, is it like the perspective, the feeling or the perception based on the follow-up you have that also, like with the web, the larger aneurysm are the one more prone to like residuals or recurrence, like compared to the small ones?
Yes, it's a great question, Eytan. Probably in the near future, we must classify the aneurysm probably less than 7 to 15, and greater than 15. Yeah, because less than 7, I think a lot of things works. Yeah, and the final angiographic result is really good, and the long-term outcome is really good. The things both a little bit more complex and a little bit challenging, greater than 10 millimeters. We only have had experience in 6 cases greater than 10 millimeters aneurysm. Fortunately, most of them with a good result. And 3 months ago, we treated 19 millimeter aneurysm with a 20 millimeter device, and the final angiographic, the immediate angiographic result was really good. We are waiting for the follow-up. Yeah. But you're right. the follow-up is essential for aneurysm greater than 10 points, than 10 millimeters. We believe that even in those aneurysms, the conformability of the device, the delivery technique is completely different than the smallest one. Yeah, because if you start the delivery in a slow motion, too slow, the blood get into the device, and many times the device looks too heavy, and the radial force would be sacrificed. For the reason, the idea and the recommendation is to deliver the device with an unsheathing technique in a fastest way as you can. Yeah, because it's different. Yeah, if you start to deliver in a slow motion, the blood get into the device, and the device looks with a misopening, with folding. It's necessary to make a lot of wagging, yeah, to get the final open. Probably the radial force is compromised when you are dealing with aneurysm greater than 12 millimeters. Yeah, just to take it into consideration. Yeah, the way and the technique that you use to deliver the device in those aneurysms. But you agree? Yeah, you're right. Sorry, you are right. The follow-up in aneurysm, in large aneurysm, we are waiting for that. Yeah, we are waiting for the results of the US trial. People in Europe have had a good experience in large ones, but still the number of cases is too low.
Thank you.
Right. Boris, thank you again so much. Exciting.
No, thank you, guys.
Yeah. Okay. Safwan, thanks for waiting.
Thank you for having me here. Hello, everyone. So, can you see my screen?
No. Now something, yes. We see the whole desktop.
Is it
That's good now.
okay? So I'm going to talk about a case of traumatic direct carotid cavernous fistula that we treated with covered stents, and I would like to discuss with you the options that can be considered in this case. So the clinical information about this case: lady, 51 years old, she fell down like 20 steps under alcohol influence with GCS 13. She has at arrival anisocoria, left more than right, and left the left side absent corneal reflex, light reflex, and according to the ophthalmologist was because of direct trauma to the eye. No other focal nerve deficits and no exophthalmos. So in the neuroimaging findings, we had like a bit of premesencephalic subarachnoid hemorrhage, and we found a direct carotid fistula that will show shortly, and some small, very small contusion in the right temporal lobe. So if you see here the TOF angiography of the MRI, so on this side we have the extensive venous flow, mostly on the right side, and just cortical reflux also on the cortical veins. In the T2 sequence, there's no really exophthalmos to see. The ophthalmic vein was not really like that much enlarged. The other findings were not remarkable.
Sorry, can can you like, do you see the cortical venous reflux here? The one you were pointing was more like the ophthalmic vein. I don't know if you saw this no matter what on this. I mean, it doesn't matter much, but
I was thinking maybe this one.
that's probably like an ophthalmic. Looks like the ophthalmic. Looks the ophthalmic vein.
Because I was thinking the ophthalmic vein should be this one here.
Yes.
So it was a bit for me. Maybe at the origin of the ophthalmic vein. Yes, at the foot of the vein. Yeah.
But the angiogram will show, I guess.
Exactly. Yes, exactly. So this is the angiogram. So the anterior view of the anterior carotid artery, the right side. This is the lateral view. Sorry. And there is no intracranial flow. And of course, you can see here the reflux into cortical veins and towards the sagittal sinus and the straight sinus. So showing the collateral flows. This is the view of the left vertebral artery. It's again the anterior view, and we have shown the lateral view. It was good collaterals, but in the venous phase, it wasn't the same phase as in the posterior area, like much delay. And this is the view of the left internal carotid artery. So just the anterior, but the media is not really have good collaterals. So
you show us the external, the right external?
Yes, we did it. Of course, I didn't have it here, but wasn't no collaterals from the external inside the right, like from the right external, no collaterals to the internal carotid artery. So the question is to treat in this patient which way? Of course, we have the collaterals. We have the cortical reflux that we showed in this slide. So I would of course go for treatment. The question is how to proceed the treatment. And as you know, there are different options to treat in such cases, like with the detachable balloons or using, for example, transarterial or transvenous obliteration of the ipsilateral cavernous sinus with coils or other embolic materials, deployment of covered stents, or to sacrifice the carotid artery completely. And as I told, the patient was completely not symptomatic, like didn't have any neurologic deficit, doesn't have any exophthalmos. The only thing that was obvious or in the neurologic examination was the vision loss on the left side, or like retardation of the loss.
You want to discuss now, or I see Dodi ready there.
No, I just continue. Is there any question?
No, I don't.
We lost your microphone. Now it's okay.
Okay, sorry. So we decided to go with the mixed approach. Like at the beginning, what the idea is to go through the with a balloon to protect the internal carotid artery and to occlude with coils the cavernous sinus. This was the material that we used, and I'll show the images how it looked. So we had envoy catheter in the jugular vein, the right jugular vein. We have envoy catheter also in the internal carotid artery on the right side, and we have injection from the left vertebral artery to show exactly the carotid artery to the right. And we tried for like quite time to pass distal to the fistula point with the septal balloon and with a wire, using different wires, different catheters even. We were not able to go distal to the fistula point. Like it was the laceration of the carotid artery, the tear in this lesion was apparently so big in the lateral segment that always the wire went inside the sinus. So we decided to go through the vertebral artery, through the basilar and through the becum. So went with Traxxas microwire with microcatheter just to have more support, and then just hugging that wire, we were all able to proceed with our catheter, with our also wire, microwire through the carotid artery. And we proposed one covered stent over the wire. So the idea of occluding the sinus with coils completely changed because the tear of the carotid was so big that I was not sure if just occluding with coils will be enough to restore the flow in the carotid artery. And I didn't want to risk. I wanted to think, okay, we can maybe give it a try, a shot to the covered stent and see if it works. If not, we still have the options to go transvenous and put coils in the sinus and protect the artery with the balloon. So it was the first stent graft, like the Boris stent. It was here for 26. And here you can see the deployment of the stent in this video, which went without any problem at the beginning. Very good. And this was the result directly after the stent. So we restored some flow into the internal carotid artery, but we can of course see a lot of rest of the fistula. So I proceeded with another balloon to make the stent more open. It was a cardiac balloon, Solaris. And this was the results after the balloon, the BTA. It looked not that bad, like small rest of the fistula to see, but I decided to continue and to try to occlude the fistula completely. So I used another balloon again. Sorry. And then using the other balloon, I pushed all the material down. Like the balloon pushed the stent down and I went back to the initial situation almost. So it was necessary to either to go transvenous or to try with a second covered stent, which was the case. We put a second distal Boris stent graft, which was not easy to bring it to that level because of course, it's not that normal stent. And opening the stent at that level was also not that easy, exactly like we wanted to put it exactly here before the curve. But as you can see, the stent pushed again with the balloon down. And we still have the fistula. So what happened is that we tried again to go through and to push the whole material that went down a bit higher. And this was an Orsladder catheter that used usually for delivering of a Caristo stent, like carotid stent. And we can see here how the catheter will move the second stent up very slowly. Don't know if it's good visible. And that's it. And then if we see the control angiography, the fistula was completely obliterated. Not completely, sorry, because we can see still here at the edge of the stent, very small flow. But I was very happy with the results. So this was the view of the whole right hemisphere. This is the DWI. The patient has some small infarctions, but not symptomatic. And this is the top angiography. We had a follow-up of the case, 3 months. and shows completely occlusion of the fistula, and the stent completely patent, and there is no other filling, further filling of the sinus. The patient was put during the intervention on tirofiban, and after that on dual antiplatelet therapy with aspirin and ticagrelor for 3 months, and now she is on monotherapy only with aspirin. So this is the 3D reconstruction. So I just want to share the case with you and listen to your questions and opinions about this approach. Thank you so much.
Safwan, thank you. Very interesting case. There were some questions about in the chat. So one question is basically about how to track it. Now, initially, just to clarify for the group, you came from above to gain access to be able to cross the level of the transection.
Yes,
The
exactly.
stent was deployed from below, correct?
Correct. The stent was deployed from below because it wasn't possible to go through the beacon with such a stent.
Right.
But it wasn't, so it was just striking from, exactly. So the stent was deployed from the carotid artery from below, and just the navigation was made through the beacon.
Okay, so just explain for the group, how do you do that? Like once you come down from above, what happens after?
So I will go just close back to. So here, for example, so the first what we did, like we were not able to proceed with our septal balloon above through the this laceration of the carotid artery. So we went with a micro wire. This was the Traxxas 14 through beacon, followed with the SL10, and the wire made the way, showed out the way where is the true lumen is of the carotid artery, and then with the wire from down through the septal balloon, we could hug this wire and just through this wire go the same way up. So it was just putting the wires next to each other, rotating the tip of the wire to go around the first wire, and then just pushing it to go around and go then completely.
So you use the wire as your map to know where.
Exactly. I use the wire as my map. Exactly.
You can call it the reverse sheeping technique.
Yes.
Yeah, exactly. Thank you.
I mean, another way that I happen to do it is with the snare, whatever. I mean, it's good that you explain how to do it. Now, the fact that you had to follow, it confirms that, it was about, understanding exactly the route where to go, right? So that was the key that sometimes with a good 3D, you can realize that, but I get it. In this case, very high flow, that can be very tricky.
We did in the fact 3D imaging, but it wasn't with our device wasn't that helpful, to be honest. Like the flow was so high that I was not able exactly to decide where is exactly the hole of the carotid artery. There were like many small holes, and when I tried with the wire to go up from down, like the wire was just swimming in the cavernous sinus. Like it was not, it was this U shape, different U shapes, and sometimes first tried without U shape, but with this U shape it was going just completely inside without any like it was amazing really how big was this or extensive was this laceration.
Like there's a lot of questions about kind of like how to push it up, support this and that,
Yeah. The pushing up of the stent, the pepper stent. So basically, like I don't have experience with many different other stents. Like I tried with the B-craft stents and with the pepper stents in such cases. And I was to say that pepper stent is more flexible than the B-craft stent. Like it can be pushed a bit higher It has the design of the stent is different from B-Craft. It's not like that sandwich design. So there is the wire of the stent, and it is just between the wires, the mesh of the covered material. So it is more flexible. It can be brought a bit higher than B-Craft stent in my experience. And in order to reach really high, it was needed to have really like support wire. So we tried with the synchro support microwire, which was giving enough support. But in some cases, which not able to go higher, sometimes we go make exchange maneuver. We go higher with the normal 14 like synchro or Traxxas with microcatheter, and when the microcatheter is not in the middle cerebral artery or anterior cerebral artery, but in the carotid artery, we exchange the microwire to like high torque microwire. There are some high torque microwire or like middleweight or heavyweight from I think Aput. And it's important to keep it in place because not to go higher intracranial. It's not recommended at all, but it gives a lot of support to bring material like Piber's stent graft or similar to this position.
And our experience is very limited with this device. We have a couple of cases. For me, I just prefer to put the intermediate catheter beyond the level of wherever the stent is going to be. Like shove something like heavier, some sort of heavier intermediate. Like here, you could get it, up to the upper cavernous, to like horizontal cavernous, and then hope that the thing goes. It's definitely the best in terms of navigability. I would say it's like the best of the worst. It's still very stiff, but less stiff than anything else we got. That's why all the cases that people show these kinds of cases now, pretty much always they're showing the papyrus.
I mean, this is a very favorable segment where to do that, right? Very favorable, straight, proximal, so I can see the advantage in this case. Now, there are some other comments. I mean, Lian is saying that, yeah, in the US, this is not available because it's a humanitarian device exemption for cardiology use only, meaning that, we will need a consent like IRB. You can do it, but it's a little more complicated.
But I think we should mention that there is a mechanism for this. Like, yes, it's humanitarian device, but it doesn't mean you can't use it. But you have to follow the rules. You can't just put it in there and be like, yeah, whatever. Like you put it in, you have to notify the FDA. You have to get retrospect if it's emergent, which it often is. There's the protocol, like FDA notification, the IRB, retrospective consent, like all of this stuff can be done and should be done by the rules. But there is a way to do it. It's definitely good to know your cardiologist. Like when we do it, like you can't come to the cardiologist and say, hey, my name is this and this, can I have one of these things? That's not good. So definitely like, just be friendly. There was a question, so Arman was saying about like, you mentioned over-dilatation, like dilating it. Like how do you say you still had a fistula after this? Our experience, so basically like over-dilate or not. It just depends on how it's sized initially. Like in the limited experience that we have, it needs to be dilated a little bit more than its nominal size for it to oppose the vessel well. So then the question is like, what is the native size of the vessel? Are we already like over-dilated? So I think the sizing, like in our experience, is not to oversize it initially, because that means you have to over-dilate it more. But if you size it right, quote unquote, to what the diameter is, then you can dilate it a little bit more after that. And it may not be too much. But like with anything, you have to be like, obviously we have to be careful. And I don't think anyone has a lot of experience with these. Any other comments about sizing, dilatation, deployment? Anyone have experience with that to share?
I have a comment, but Krishna was before me.
Safwan, great case. I just want to point out the fact that, as you had said before, the wire easily going through the level of the rent into the into the cavernous sinus, I think most people would have taken that as a sign to just sacrifice the vessel, especially in the absence of what you're saying, in the absence of any ischemic symptoms. There's no, at least clinical evidence of steal phenomenon, despite the fact that the collaterals on the left internal carotid artery run would suggest that maybe there wasn't great flow. One of my questions was, once you had access into the true lumen, did you consider, deploying multiple flow diverting stents? We've done that in these situations, covering the vessel, obviously not as good as a covered stent, or jailing a second microcatheter, which was so easily able to get into the rent, putting a stent across and just, coiling off the fistula. And then my other question is, what do you think happened in that?
I think
It looks like in your second balloon dilatation, you migrated the first stent away off of the level of the fistula hole. What do you think happened in that second
I
dilatation?
lost your voice. Sorry for seconds. The last two sentences, please. I lost your.
Oh, my question is, once you had access to the true lumen,
Yes.
did you consider, deploying multiple flow diverting stents, which may have been reasonable in this situation?
Yes.
The
Yeah.
corollary to that is jailing a second microcatheter and coiling off the fistula. And then a separate question is, what do you think happened in that second balloon dilatation, where it seemed like you had a decent antegrowth pacification, but it looked like you did a dilatation for a second time and you migrated the stent? What do you think happened in that situation? Those are my questions.
Thank you. Thank you so much for questions. So for the first question, like I thought about putting flow diverter in the carotid artery, but I was, to be honest, skeptical about that it's going to work in such a high flow. So I wanted to give a covered stent a shot, and I was thinking, okay, if this not going to work, if I could not able to bring the stent up there, then this would be like my second option, to put a flow diverter maybe there, and or maybe just try put some coils in the cavernous sinus with the balloon occlusion of the carotid artery. But I wanted to give a shot for the covered stent to see if it's going to work. So, but of course, yes, multiple flow diverter may of course will reduce the flow with combination with the coils. I think it would work. I'm not sure if only flow diverters alone is going to be efficient in the. I don't know if the experience of others, if they have experience with that, but I am skeptical if only flow diverters or 2 or 3 at the first time is going to
It's
reduce
not gonna work.
that much.
Flow diverter only are not gonna work. I mean, like, with such a high flow fistula, it's not gonna work. I mean, I'm sure if someone has an exception, it's gonna show, but I would say that's an exception.
I just wanted to emphasize the beauty of covered stents and of grafts. So these are beautiful devices. Of course, they are rigid, they're stiff. There is a problem with guide bar, with catheter, and that's the reason why many, many years ago, like 20 years ago, I continued to ask to the companies to make a covered flow diverter, which would be the perfect solution for this case. You need a normal catheter, you don't need stiff anything, and you just deploy it where you want it, it curves, and so on. So probably the market is too small for that, and the companies are not that much interested in that. But for carotid cavernous fistulas, but I guess also for some large and giant aneurysms intracranial, that would be a perfect solution. So we should push more to have covered flow diverters. And but thank you for the case, because it's beautiful. Yeah.
Thank you so much for your comment. I just want to come back to the other question, like about how the stent went down with the balloon. So it happened, like, if I show again just quickly, when I dilated for the second time, maybe I could, of course, I could here in this stage, I could just leave it, not here, sorry, there. Maybe I could just leave it and just coil the sinus for this small rest that was still here. I didn't. I went for for the balloon. And the thing is, when I went with the balloon to make another dilatation, the balloon was a bit higher, like the balloon was higher than the stent, part of it, and it went distal to the stent. Like it's just, how to tell, it's maybe run away with the stent distally in the carotid artery and push the stent down. So I think I went with the balloon more distal than it should be. That
The
was the
balloon
reason
is
why.
coming from an antegrade approach at this point, correct?
Exactly, exactly. So I think I went higher than I should be in this case. I could be a bit proximal and then not going distal to the stent, and that's why with the balloon went higher in this curve in the carotid artery, pushed everything down. Then I needed to try to push. I was lucky, to be honest, to push the things again back. It's not the way it always happened, and yeah.
Yeah, I mean, similar to, I guess, balloon dilatation of, again, flow diverting constructs, you try to get distal apposition first and then bring the balloon more proximally, right? That stent has to go somewhere. And in this case, it seemed like it fell down. But yeah, fantastic save and push and bumping that second stent higher up. Really wonderful.
Thank you. Thank you so much. This other question from Vittorio.
Yeah, I have a question. Thank you. Beautiful case, very elegant solution. And but I have a question about your and if others has this experience on long-term. I mean, in terms of patency of the stent in a long term, because I have this notion that maybe they are a tendency to close after a while in a quite high number of cases. Maybe it's a wrong notion. So maybe if you and Maxime that have experience in this field, I don't know, because if it stay open, it's a very, very elegant solution. I agree with Dodi, of course.
If I may say, to my experience, limited experience, till now, we didn't have any occlusion, but we don't have long follow-up for, like, let's say 3, 4 years or 5 years. So I don't know if any vaccine will have more experience with the follow-up of such things.
We had more or less 30 cases intracranial covered stents, and we had one occlusion in the long-term follow-up.
30 cases?
30, 30.
30, so.
What was
Okay.
your regimen? What was the
The-
antiplatelet regimen?
Yeah,
The usual.
in 30
Um,
years though, right?
The usual, I'm sure it would, but like, for how long? I don't know, Dodi. Like, you ask 5 people, you get 10 answers about
I
how
don't
long.
remember
Which
because
one?
it was a long time ago, but anyway, it was usually dual antiplatelet ticlopidin and aspirin. And after probably 6 months, 1 year, we just left the aspirin. But anyway, so we had, I'm sure, one occlusion, where asymptomatic in a carotid cavernous fistula, and all the rest remained pretty much open. There was a stenosis, intimal hyperplasia we treated with redilatation, and that was more or less it. Yeah.
I have no experience using these devices, but the senior neurointerventionalists certainly love them. Dodi, can you speak to your experience about detachable balloons in this situation?
Yeah, even better. But the good thing about detachable balloons that they go straight into the hole, you inflate it, and they occlude, and you have a wonderful vision of the anatomy immediately, and then you can decide to detach it or not. Usually when you detach it, it moves, so that the perfect result you had immediately changes a little bit and the fistula reopens. And so you have to use a second balloon, but it doesn't go because there is a first one. So it's a lot of fun. But usually you have to, it's not an immediate success. And then you have the fact that they will deflate over time. And so you usually have a pouch where the balloon was, where the hole was. And that pouch may be absolutely asymptomatic, but sometimes it may enlarge and give you a sort of giant aneurysm of the covered stent. So that's the reason why we started to use covered stent in this situation, and we loved it. But it was the first UMED, which afterwards became the Abbott stent graft. So very stiff. There was two stents, one inside the other, with the plastic between the two. So really, but it worked, and we loved it. Because why? Because immediately here you have a restoration of normality, which even with front diverted it doesn't happen. With when you open a covered stent, you have an immediate result, success, and you say, "Wow, this is one." There was a, like in his case, no, there was this awful fistula, blood everywhere. You open the stent, and wow, everything goes back to normal. So, and that's the only device that gives you this wonderful emotion. So yeah.
Now, Dodi, these 30 cases were not all direct fistulas, right? You were talking about also aneurysms or other
Yeah.
conditions.
Dissection, the intracranial, and these are the intracranial
Yeah.
cases. Yeah. So aneurysms, a giant, more or less giant, carotid ophthalmic, and also one dissection of the middle cerebral artery. So we went up to the middle cerebral artery with a covered stent, and that was a beautiful case. Before flow diverters, of course, because we had no real solutions, and again, we showed that stents were better than coils in many situations, or extrasaccular was better than intrasaccular, to go back to the previous presentation. So it's me?
Yeah.
Excellent.
Yes, Dodi, please go ahead. Share your screen.
Okay. Do you see it?
Yes.
Yes, yes, or yes?
Yes. Yes.
Okay. So dural, epidural, intradural, quasi-dural, and other mysteries. What are we talking about? We're talking about this. So I'm sorry I don't have the clinical history, but it doesn't really matter. This is a dural AV fistula, the usual left common carotid dural petrous bone dural AV fistula. This is a left common carotid injection, and the left internal carotid injection. So I let you look at the images. This is the external carotid. So the usual dural AV fistula of the petrous ridge, more or less where the superior petrous vein is. And as usual, you have the pial feeders coming from the cerebellar arteries, as you can see here, petrous feeders. This is the right vertebral artery. And if you want to see the veins, these are the veins supratentorial, these are the veins infratentorial. Nothing really interesting. So we treated this with fill, with an arterial approach. You can see where the fill went. And
why not surgery? Sorry to interrupt. Why not surgery?
No. In dural AV fistulas, the first option is endovascular, except the ethmoidal ones, where if you don't have a safe endovascular approach, which could be the external carotid artery or the meningeal artery, or a venous approach without too much complication. So yes, in general, the dural AV fistula first option is endovascular. This is the lateral view. Okay, 1 year later, the left common carotid, no more fistula. Lateral view. You can see the before and the follow-up. external carotid, left vertebral artery, no more fistulas from the superior cerebellar artery, lateral view. The veins follow up. So it's the usual dural AV fistula, perfectly treated. So what's the point? Okay, maybe you didn't see it, but there was an epidural AV shunt at C1 around the right vertebral artery. The epidural AV shunt was already present before. I don't know if you didn't see it, maybe I didn't show it, but anyway, this was before, this is now at the follow-up. Again, here was before the treatment, so the epidural shunt before treatment of the intracranial dural AV fistula. And this is the follow-up, again, same thing. So it's an epidural AV shunt in a previously treated intracranial dural AV fistula. What's so interesting? 2 points, maybe 3. So this is the 3D reconstruction, and you can see that the main feeder to the epidural of fistula, but then you can also see the anterior spinal artery and an arterial tangle from the anterior spinal artery that goes into or towards the fistula. So anterior spinal artery and some little vessels in a network to the fistula. Same thing here. These are the MIP images. So the anterior spinal artery is contributing to an epidural AV shunt. You can see the big pouch, venous pouch around the vertebral artery, and the pial feeders coming from the anterior spinal artery. So there are feeders from the anterior spinal artery. Does that mean that is it really epidural? And then there is one more point. Not only is draining into the epidural veins, but it's also draining in a pial vein, the pontomedullary vein, ascending from below to upward. You can see it here. Okay, and I think it's nice, it's beautiful. And of course, if you go to neuroangio and you on this page of neuroangio, which is the anterior pontomesencephalic vein, you will see that this is the vein we are talking about. This is the anterior spinal artery, and this is the vein. This is anterior spinal artery, and that's the vein going up, going up, and going up. The last interesting point of this case, had you already seen that vein? It's the same intradural pial vein that drained the previous dural AV fistula in the opposite direction. So before, when there was a dural AV fistula of the petrous bone, we had seen that vein coming from the fistula and going down. See it here. This is the vein coming from the fistula and going towards the epidural side. So before we saw it from above, and now we see it from below. Of course, it's the same vein. Before from above, and now from below. So the conclusion, it's an epidural AV shunt, feeders also from pial arteries, drainage also in the prepontine vein, which was used in the opposite direction by an intracranial dural AV fistula. Do you think this is interesting? Have you seen it? I wanted to finish here, but then a few days ago, thanks to Dr. Pietro Panni of the San Raffaele Hospital in Milan, he called me to see another case. And this is a 26-year-old man, which 15 months ago had this fistula. Again, same fistula on the petrous ridge, same side. You can see the fistula here. And again, with the same pial contribution to the fistula there, but also with the same epidural AV fistula below on the cranio-cervical junction. The petrous fistula was treated with onyx, and now last week, 15 months later, we are in this situation. So what is this for you? Is this an epidural AV shunt? But then it was noticed that there was a vein again draining intracranially, and for this reason, yes or no, this drainage was considered an indication to treatment. And the treatment considered was to get here in the venous pouch through a venous approach. And Pietro went there with a microcatheter, but this is the most interesting image. You can see a little tiny bubble of air in the epidural space. But then I will go back a little bit here. I just let you see all this. Okay, so this is the anterior spinal artery and anterior spinal vein. This is where the anterior spinal artery gives a feeder to a shunt here somewhere. The spinal vein is here, and we can see where it receives blood from that shunt. But the interesting thing is that all this tangle of vessels is really intradural. It's on the surface of the spinal cord. Extradural is around here. So all these vessels are both extradural here, epidural if you like, and all these vessels are intradural or on the surface of the spinal cord. You can see this also on a AP view. Nope. So this is on the surface of the spinal cord, and all this is epidural. It doesn't really look like a venous pouch anyway. It looks like many small vessels, what I might call a nidus. These are still images, so you can see the tangle coming from the anterior spinal artery. See the anterior spinal artery coming down, and this kind of nidus there. So I decided to go on the internet because I like to look at the pictures, and I found quite a number of cases very similar to this, and this was called epidural arteriovenous fistula. And look at this. Again, you see the anterior spinal artery going to the same place. Anterior spinal artery joining a fistula, let's say epidural. This was a study looking at dural and perimedullary arteriovenous fistula, and you see a lot of nice drawings, and maybe in some of these it looks really like ours. And then this one calling cranio-cervical junction arteriovenous fistula And again, same thing, the anterior spinal artery and a epidural, whatever. So it seems finally to be a rather common finding, even if it's not completely clear. You will tell me how often you have seen it, and we will discuss it. But where is the shunt? Is it dural, intradural, epidural, quasi-dural? So my conclusion number 2 is we had 2 similar cases, young males with a petrous dural AV fistula and an epidural shunt at C1, C2, more or less. Are they really epidural AV shunts? There are pial feeders. There are nidus-like vessels, both epidural and intradural. The drainage is both intradural and epidural. So is it an epidural AV fistula, or is it a dural AV fistula with pial feeders? Or could it be a metameric AVM, both intra and epidural, or a nerve root AVM in association with the classical dural AV fistula intracranial? So I think the interesting thing here is that they both had a petrous dural AV fistula and associated with an epidural shunt at C1, C2. And I really prefer to think that it could be an AVM more than, whatever. So do you think this is interesting? Ciao. Are you still with me?
Thank you, Dodi. Very, very nice cases and very extremely similar, indeed. I mean, there's a lot here to discuss. One of the thing I would say, the supply from the anterior spinal or whatever, from pial vessels to like these vascular malformation in this location. How often we see it and what does it tell us? And I have to say, I've been observing this often. I would say, especially in the upper cervical spine. I've seen it once also in the lower cervical spine, but mostly in that location. So I think that's where really I think the imaging that certainly had improved in the last decade or so may give us more insight about this. So I believe that's not a very, very uncommon thing to visualize. So talking about that, so I don't know if Adar has comment about this particular topic before talking about the other points.
I don't know if Keisuke is listening, but Keisuke Yoshida, who is an author on one of the papers that you mentioned, I think is connected. Don't know if he's maybe he'll comment later.
Yeah, I'm here.
Okay.
What about it? About the connection? Oh,
Yeah, we can hear you. It's you also described this kind of angioarchitecture.
oh, yeah. It's I had a similar case, so we will publish shortly. So please read that article.
I mean, it does look like, right? Like we have classifications, right, Dodi? Like we think of is this dural, epidural, whatever. But from the standpoint of location, if we're gonna say location, like certain locations that seem to have predilections for certain angioarchitectures, right? Just like a petrous apex dural fistula, which some people would say, well, how is it exactly dural? The draining vein is, so but they are similar to each other, right? They have a certain way of being of the supply and the venous drainage. So the angioarchitecture is more maybe location driven. The classification we love too.
Okay, but now talking about that, where is the shunt, right? In these cases, right, that Dodi show, where is the shunt? My take, right, is that it's a dural fistula, and it's just because of what you just said, Max. These tend to have this sort of like a little more specific appearance, but my most likely the easiest way explanation is it's a dural fistula. Now the association with another dural fistula is something that we've seen, and I'm sure Dodi you've seen also in other location, right? You have a dural fistula, you have another dural fistula, sort of like that kind of you can think of that one may influence the development of the other somehow, and so but in a patient with one dural fistula, there can be another dural fistula, and I think that I would say my easiest perspective of that.
But it would have to be then a dural fistula was like a very extreme predilection for recruiting pial supply, which is completely different from the thoracic or lumbar spine. You know, so that would still be like kind of curious, no?
Oh yeah.
I once I like commented on this, like we had a discussion with Radesh about this, and his feeling, I think he was very categorical about it, saying that the fistulas in this location are pial. He's not here to, but he's like, no, these are pial fistulas. Of course you have pial supply. So like, okay, that's a very different perspective.
Well, though this case it didn't look like that, right? At the beginning, if it was a pial fistula, why would it look like that at the beginning and then change in that direction later on?
I mean, I'm what to say, like, yes, but you have like highly experienced people with like very different opinions about these things.
No, but I mean, if you look at the contribution of the anterior spinal artery, if it were a pial fistula, it would go directly into a vein and you have a pial fistula, okay. But then there it goes into a network which is rather well developed. And even if it were a dural, like you say, Eytan, if it were a dural AV fistula, you wouldn't expect all those vessels on the surface of the spinal cord rather than close to the point of fistula. And second, what happens outside? Because we also have vessels going into veins in the epidural space. And this second case, I couldn't show it to you, but he had an epidural AV fistula on the other side also. So on the right side, not dural, not dural, it's just outside, and the epidural fistula in those locations are quite common, I think. So we see them without being dural AV fistulas. So it's more complicated than that. I'm sorry. We still have to understand. Probably again, as Maxime said, we have a classification which has holes everywhere, and we need to think a little bit outside the box to understand. There is some shunt there. Why is there? Is it coming because of hormonal changes, traumatic something, ways of placing your head when you sleep, or is it congenital? No, congenital, no. Yeah, so anything could be different. But this is interesting to me because it really tells you that in that location, something strange happens at all levels. Intradural, epidural, on the dura, and you have vessels which normally go to the dura, vessels which normally go to the pial, and so on. So we need to see more of those and try to have those good images, as you said, Eytan, more and more to try to understand it better. So I thought we would have seen some vessels going into a pouch, a vein, epidural, and I would have understood better all this. Now, some little vessels coming from there, and then you have a pouch around the vertebral artery, a venous pouch. And you occlude that and everything, like epidural spaces, in the lower spine. but it looks like it's a little bit different there.
But Dodi, but do you think there was some dural feeders to the cervical shunt
In the first case and the second case,
in your case?
in my case, no.
The dural feeders were for the petrous shunt. I mean,
Yeah.
and
We
then
didn't
there was
test-
a shunt down there at C1 level that was fed by the anterior spinal.
Not
Is it
only,
right?
no, on,
Not only.
also from extra,
Okay.
extra, extradural, let's say muscular or
Muscular.
whatever. But
Yes.
these are the same vessels which normally go also to a dural AV fistula of that region, especially of the foramen magnum dural AV fistulas. Now you have
Yes.
those little vessels coming from the vertebral artery, which we call meningeal, which could be, could anastomose with the lateral spinal artery, which could anastomose with cervical muscular or bone vessels, which could anastomose with pial vessels and so on. So it's a big network. Vessels are everywhere. But anyway,
Yes.
it's just.
I have a couple of comments, Dodi.
Yeah, sure.
Quite not questions, thoughts. I don't know. So we showed you, including yourself, like we had like a really, I don't know, remember when in Bananas, but it's on YouTube for those of you that want to see it. We showed like our experience, yours and many other people, with these kinds of multifocal. It's kind of one vein. You have a vein, and you have several shunts, right, that are draining into this vein. And sometimes you have it like a temporal history. You have this one shunt, and then you come back later. Another shunt happens to be like now associated with the same vein, like slightly more proximally or distally, right? So we show that's also kind of, to me, seems like on the spectrum of what we're talking about. Like, is that one way of thinking about this? Like, could there be something like this going on? It defies classification. It's not a classification. You have a new shunt forms, right, in a different location.
Yeah. So which one is the vein we are talking about? And that's first question. And second question is, why though so many vessels? You need many less vessels to have a shunt, of course. So it's like there is an abundance of vessels, something that you would see in an AVM. That's why I'm thinking of an AVM. It's more like when we see an AVM, we see a tangle of many vessels which we don't understand, and we say, oh, that's a nidus. Okay, so it looks like, to me, it looks like a nidus, both intradural and epidural. So we have seen that sometimes on the nerve roots, really, AVMs on the nerve roots that, of course, follow the nerve root, which is a little bit intradural and a little bit extradural. So maybe it's that. And it's just an idea, of course. But otherwise, I don't know what vein would be the one you are talking about, because there are multiple veins there, both extradural and intradural.
Well, okay, so then it leads to this question. I also very much believe in like this concept of classification of, say, dural shunt, because it tells you where the holes are, right? Like if it's dural, you know where the holes are in which structure. And I think that's right. That's a lot of times the confusion happens from people not understanding exactly where the shunts are. On the other hand, let's take like the opposite approach. Let's say we have like aneurysm classifications that are historically based on external landmarks, right? Surgical landmarks, clival aneurysms because you're drilling the clinoid or whatever. These classifications don't apply to endovascular cases because needs different idea. What about this kind of thought? Like, okay, we have these classifications are based on these external structures like dura or epidural space. It's not like a priori vascular type of environment. What if we considered shunts based on the angioarchitecture primarily, as opposed to like where specifically they are, which leads to this thing about where the arteries are, where the veins are. If we can identify, typically what happens is there's some sort of like mess and this and that, like as you said, but then there is something that we can, I think most of us can agree is the vein, or at least we can agree on what needs to be closed. Like the practical thing about this is like, what do we occlude in these things? And so if the foot of the vein is what we occlude, you know, in many of these. So what about this idea that we're going to say, okay, this epidural, dural, I don't know, but can we identify the vessel that collects these things?
Yeah. Unfortunately, the vessels were different vessels. There were epidural vessels draining into the epidural space. There were epidural vessels draining in cervical veins, muscular veins. There were intradural vessel veins draining into the pontomesencephalic vein. So there were many veins, and I don't know which one was the one. I think we need to see more and to discuss more, and that's why we are here. And maybe I thank you for not being bored about these cases, but it's part of our understanding. Krishna.
I have one question, Dodi, about going back to this nidus that you're seeing. You know, we've seen, you know, in your bread and butter spinal epidural fistula, where you see the feeding vessel along the nerve sheet root, what appears to be a, you know, I'll call it a collection of vessels, not necessarily a nidus, but in those situations much lower down in the thoracolumbar spine, we truly epidural fistulas. What about this made you call it a nidus per se? How did you know that it wasn't just the collection of epidural vessels? We've had a couple of cases where you truly see a nidus that is, I'll just call it intraaxial, truly intradural. But what about that nidus, as you called it, made you, again, maybe semantics, but what made you call it a nidus versus just a collection of epidural vessels? And how do you distinguish the two? Because you specifically called that collection of vessels a nidus. And I guess my question is, how do you, if you're assuming a priori that this is all epidural, how do you distinguish between a nidus and just a collection of epidural vessels?
No, you're completely right. The problem is when a collection of vessels becomes a nidus. We don't know. But it's kind of a gestalt appearance that you see some, you know, many vessels, all one inside the other, and there are too many compared to what we would see in a dural AV fistula. So even in a dural AV fistula, when you see the pial component, they are separated, they are nicely seen, and they go directly to the vein. But here you have, before going to the vein, whatever it is, this bunch of vessels, a tangle, whatever, which is separated by whatever the lesion is. That's why I call it. It looks like a nidus, but it was a little bit a provocation from my part, and it's not really because I really believe it and I want you to believe it. It was just a suggestion. It looks like an nidus. It smells like an nidus. It behaves like an nidus. It probably is an nidus. No, I'm just kidding, of course. So I don't know. I don't know if you want to go back to see the image, but we don't have the time because the images on the you will see it on YouTube. But if you go back and look at the images on of the Dynasty T, which is not a Dynasty T, is whatever it is, vaso-CT, yes. It really seems different than just pial components and contribution to a vein.
I think there's a question from Nidal.
Yeah, it's a very good question. Should we treat these lesions? I don't know. We don't know. If it's so small and so limited, the shunt to the pial vein, maybe not. I don't know. It's something that we could discuss. In the case number one, the one in my hospital, it was not treated. In case number two, it was. But of course, it was not treated. It was tried too. There was an attempt to treatment. There were coils placed in a venous pouch outside, not outside the spine, but without any real change in the overall shunt. So there was an attempt to treatment, but not really treated.
Has anyone else had the similar experience of this location being difficult to treat by trying to stuff the epidural plexus? Because I think we have. I don't think they're so easy.
We had a case where we did actually a direct puncture in that location and went very well. It was curative. You know, it's an exception, you know.
Yeah, but what do you inject? Because you have feeders from the anterior spinal artery, you have feeders from the vertebral artery. So whatever you inject could go in the wrong direction. If you place coils, you need to be in the right foot of the vein, which in this case it was not accessible to whatever. So yes, I agree with that. So in your case, it was really it had an intradural component, or it was just epidural? Because
it's from quite a few years ago, so I would have to go back and review the details. But
okay.
the patient had an intradural aneurysm. I don't remember if it was on the venous side or arterial side. I have to review it.
Okay.
Can I comment?
Of course.
Can I comment about a case like this? I uploaded 3 weeks ago epidural dural fistula like this C2, C3 level with an aneurysm in the radiculomedullary artery that ruptured. There's a fistula was on the left side. The supply comes from the right vert to the left to the anterior spinal artery to the left fistula, and the patient bled from the aneurysm in the medullary branch. So the reason why they have this is that there is connection of the radicular artery, as Dodi said, between the radicomeningeal, radicopial, and radiculomedullary. So if there is demand, so the supply can come from the anterior spinal artery to the fistula. If you go back to 3 weeks ago in the neuroaddict, you will see the case with explanation how to do the transvenous approach and to occlude the fistula by putting coil and then filling it with squid and occluding the fistula. I will not recommend anyone to treat it from the arterial side. There is a lot of pial and radiculomedullary artery in this area, which you don't see them, and you can occlude them and cause severe spinal damage, which can cause severe disability. So the best way is transvenous approach. So if you want, you can go back 3 weeks or 2 weeks, you will see the case, a nice case. This
Yeah,
Maimon.
thanks,
Thank
Maimon.
you.
I think I know what you're talking about. We are. I mean, we are also. I personally am quite conservative in this location with like transarterial injections for the same reason, because there's contributions, whatever, peel, whatever we want to call them, they lead to the cord one way or another.
You don't see them many times. You
And
don't
many
see
times,
them.
No, you see them. You
It's
see,
too
and you
small.
see them in the OR when you go when we go to see what it
Sure.
looks like in the operating room. There's always more to see in the operating room.
Yeah.
Right? There's always
Yeah.
see more vessels, but here you're like, wow, here it is.
So this.
So we.
So I agree with Dodi. There is a problem to this. I don't know if we can say exactly if it's dural, epidural. I don't think it's pial, but no doubt about it. This area have a lot of vessel, which all the definition is not so simple. So I called my case dural epidural because I cannot, because the drainage was epidural, it's not intradural, but the supply come from pial. So he said, how do you call it? No doubt about it. We have some, we don't see so many of this to know exactly how to call them.
But Maimon, thanks for being here. Thanks a lot. In your case, when you injected squid, do you think, of course, you injected in the vein, do you think it could have gone through the AV shunts and go to some arteries? Because that was the idea
So
why
this
I
why
didn't want to.
exactly this is why I put a magic into the radicular branch from the vertebral artery while I was in the venous side to be sure that I'm not feeling the arterial side, and then I will cause damage. No doubt about. Also, when you do injection from the venous side, you easily can push your squid, whatever you inject, retrograde back into the arterial side and can cause damage. So you have to be, the injection is very slowly, very carefully. You have to be very sure that you are filling only the pouch. And I stopped, didn't give it to go more than this. And yeah, this is one of the problems in this area. You all the time have to be careful that nothing will go to the pial or radiculomedullary artery. We treated the woman because she had an aneurysm in the anterior spinal artery. So that bled. You cannot leave it. So we had to occlude the fistula to reduce the demand from this vessel and give time to the aneurysm to collapse, and it collapsed after 3 weeks. But no doubt, I agree. This area is so dangerous. I can tell you that my colleague, I was not at the hospital, he was lucky that he tried to do it transarterial, but they have thrombosis and they have spasm, so they had to stop. They didn't understand the meaning, and the patient was lucky, and they was lucky.
One thing I would say I kind of disagree is the fact that we don't see them, the supply. With modern imaging, good resolution, we do see it. We do see it.
Not all of them. You think that you see them.
We see them.
Some of them are
but it's
micro.
enough to see one, right? It's enough for when you see like Dodi showed very well, or we have plenty of cases, you do see that. So I think that's a strength of modern imaging, like in terms of safety as well. Yes, of course, we need to know no matter what. The cultural background is extremely important, but I think there's certain location where the modern imaging absolutely helps everyone in strategizing.
What I want to say, it's not that we don't see. We see only part. Why? Some of them are on micro level. So when you inject the squid or something, you will see them sometime. But sometimes only the DMSO itself can go through that vessel, tiny vessels that you don't see under the angio and can cause damage. In this area, those vessels can be in microscopic level. So you don't see them so well in angio. And this is why I'm trying to say, the meaning not seeing that they are there, but it's sometimes below.
Yeah. No, we agree. The danger, like the how to say, the distance between safety and
exactly.
danger here is extremely subtle. Extremely.
This is what I mean. This what I mean. And this
No,
what Dodi said about that what we have to be afraid while you inject transvenous, you can feel those vessels and you're not so sure that you didn't feel them. So this is one of the risky area. It's a risky area, no doubt about it. If you don't have to treat in this area, better not to touch.
Okay. Now I do have a question, and maybe we're running over time, but Maimon, you mentioned the DMSO toxicity. And I don't know if we're going to come to an answer here or not, but personally, I want to raise my how do we know that, like, what is the evidence for DMSO toxicity? Why do we think there's DMSO toxicity?
I will ask you something. Have you ever seen with glue reaction when you inject into cavernous sinus? The patient doing bradycardia, have pain, and is sometimes nearly asystole? Why not?
Well,
Because
the cardiac reflex, I think we see with like any injection.
no, if you inject the DMSO near the cavernous sinus sometime, and you can see a reaction which you don't see with other material. DMSO, I will never inject DMSO in spinal system. I would not take the risk. I believe that it's little bit toxicity, and so I will not use squid onyx in a pial medullary vessel. You can do it. I believe from what I have seen with the other area in the brain, that this material is with a lot of reaction. So it could be that it's fretting too much, but I never use in 25 or 20 years that I never use in spinal system. Also in brainstem, I don't do it.
But we're willing to do it in small vessels in the cortex. Why? Because the cortex is different, or we're okay to tolerate damage
Exactly.
there?
Exactly, because the option to tolerate is far better. The brainstem is not the cortex. And the damage in the brainstem can be far more disability than if you damage any area in the brain.
My problem with DMSO toxicity is that anytime people inject DMSO, it's followed by injection of something else, which is an embolic material. And then there is an issue. There's some sort of deficit. And the deficit, then the answer is, well, is the deficit due to the embolic material or due to the DMSO? So I'm just not so sure that we're blaming DMSO for the deficit that may be caused by something else. That's my
no,
issue.
I know. Okay, I understand what you mean. If you look in the reaction around squid onyx injection, the edema around, it's far more than what you see when you inject glue. Why?
That could be because of what was occluded. It may be that the occlusion is better and now there's edema around an occluded vein. I mean, we don't have pictures. We can discuss like around concepts.
What you see is it's not edema of occlusion vein. You see edema of reaction of the tissue to something. Because when you occlude a vein, the edema is a different appearance. It is not the same appearance. I agree with you. There is no clear evidence, only in the basic work that was done in the beginning, showing on histology and pathology, necrosis in tissue. If you go to the basic work, when they publish about onyx, they show necrosis in the tissue at the area of near the DMSO. This was the only pathology was shown, if I remember. It was, I think, it was presented in Val d'Isère in one of the meetings, 15, 20 years ago. You have to go back, to the old literature.
No. Okay, I mean, yes, that point is well taken, but we ourselves also prefer to use glue in like spinal dural fistulas, not for this particular reason. And maybe this is like, it's a discussion we can continue offline because we're not going to get to to the truth of it.
No, we don't have data.
I don't think there's enough data.
No, there is no data.
I find, yeah. I mean, I'm just like, I guess I'll just leave it that I'm a little bit more skeptical about DMSO toxicity.
In spinal dural fistula, I can sometimes use squid or onyx, but it's not the same. It's not pial vessel. It's not pial vessel. This is meningeal vessel. But if you ask me if I have any clear data, no, there is no. The only thing that I remember is the pathologies are shown in the beginning before they start to use in the public to manufacture to sell onyx. The work was done and showing necrosis at the area of the injection. Why? you can say, okay, they occlude vessels, they cause necrosis. It could be an option.
All right. Maimon, do you have cases to show? I think you do. Do you have anything?
I'm sorry that I didn't have time to prepare. I did also last week, a spinal dural fistula too. But I will upload it tomorrow in the NeuroAddict because I didn't have prepared it in my computer, so I cannot upload it here.
No problem. I didn't say, I didn't want you to,
No problem. Next time.
show. Maybe we'll do next time.
Next time.
Yeah. Thank you. Thank you.
Thank you.
Yeah. I think so. We have like maybe another 10, 15 minutes. As usual, we go late and there's a lot of people on. So if you want to stay on, Eytan has, for closing, some things to share.
Okay. Do you see my screen?
Yes.
Yes.
All right. This is an interesting case that I had recently, and it's good to talk about the approach and that we may have different, and again the role of imaging to as a incredible change, I would say, in our practice. 76-year-old patient presents to the ED at 2:30 p.m. With a sudden onset of right eye, very cloudy, like right eye vision loss. That started at 10:30 a.m. And went to the ophthalmologist, who excluded retinal problems, and he suspects central retinal artery occlusion and sends to the ED in our hospital. Arrives, is evaluated. Now, the CT obviously is done immediately. And as you see, there is an old, she actually has right hemianopsia from an old occipital lobe infarct. But now there's obviously this new right eye only vision loss. And, no hemorrhage and no other intracranial or orbital problem. So they inject TNK. So patient receives TNK as part of the stroke treatment. And then after this, is it something to consider to bring the patient for IA intraarterial treatment? Interestingly, after TNK, there is a slight improvement of the vision. Unfortunately, I don't have the details of the ophthalmologic exam. So if you ask me details about, I have the follow-up one, but the baseline one I don't have because it was an out, like in an office. So I don't have the notes essentially. But let's say the expert were all in agreement that there was a CRAO here. And so is it something to consider to bring the patient for an intraarterial injection of thrombolytic? The evidence is not very good with this, right? There is the Eagle trial, like we're talking about many years ago, 15 years ago or so, that failed mostly for safety issues. Like in the therapeutic arm, there were more hemorrhage, mostly related to TPA, and then more recently presented at the European Stroke Conference, the 10 crowds with indeed TNK that didn't show like effectiveness. Now, is it something we would consider to offer IA treatment or not? So here, my approach was like, let's be very extremely honest and straightforward with the patient. Let's say exactly about the risks of injecting potentially more thrombolytic and the not obvious effectiveness. And after an extremely long and straightforward, honest discussion, the patient was absolutely adamant because she already had this issue with the hemianopsia and she wanted absolutely to try. So we agreed on moving forward and went to angio, and this is the right ICA. It was a right eye issue, so I I wanted to be extremely safe with the procedure. I just went to the right ICA, and you see something, which is whoever does this knows, like, the fact that you see the choroid blush doesn't mean that the central retinal artery is not occluded. So first, an anatomical, very important message, right? The central retinal artery occlusion not necessarily is associated with loss of the choroid blush, because the choroid blush, the vast majority of the choroid blush that we see is supplied by the ciliary arteries. There's minimal contribution to the choroid blush by the central retinal artery. What happens is often the ciliary vessels and the central retinal artery, they originate together. So if an occlusion of the common trunk happens, you're going to have loss of the choroid blush. So, okay, so we see this. Does it mean that the central retinal artery is not occluded? No, it doesn't mean that, right? Okay, so essentially here it's almost like the approach is regardless. We're going through the ophthalmic artery, right? And we do a run, again, like to visualize here, like try to understand a little more if we can, and inject TPA. How much? By the way, like we go inside, and here, at first glance, I didn't recognize it. I decided to do the treatment regardless, even if I didn't analyze anything. But here it is. This is a finding I'm going to show you a little better later on. There is indeed an occlusion of that vessel. And I did indeed also, before injecting, I did this is the magnification image of that shows, there's something odd there. And I did a Dyna CT, like with a microcatheter hand injection. This is an RT skew, so the image you're seeing is actually I did both a 20-second and a 5-second, because the 20-second was very much artifacted with venous contamination. So I decided to do the 4-second, which is this one. And with secondary reconstruction, even the 5-second with the RT skew, the 5-second injection with a good secondary reconstruction and good injection, indeed, it shows very, very well details, and not necessarily the longest protocol is always the best, because you also want to avoid venous contamination. And here, when you see this, it's pretty obvious that what I was pointing to you before is pretty real. Here you see there is a cutoff in this vessel. And, you can do some reconstruction of these, and these are like, an axial and a sagittal reconstruction. Again, this is RT skew. This is not the last, this is the one before the last generation of Siemens. You do not need the last generation machine to get this level of images, okay? And here it is. You see the central retinal artery here with a cutoff. And interestingly, you see the cutoff. And interesting, there is reconstitution later from another branch, actually, of the central retinal that runs along the nerve and then gets at the level of the nerve more distally to it, which is reconstituting. This is what we're seeing here. It's something that we're extremely familiar with the brain. This is collateral filling distally to a point of occlusion. So all this analysis that I'm showing you, I didn't do it live, right? I was able to spend time later and looking at the images, but whatever, in the hurry of the moment, I went inside with a microcatheter and I inject 4.5 milligrams of TPA, which is a conservative amount. And the reason why I gave a conservative amount is because the patient already received TNK, and I wanted to err on the safer side. We can discuss how much people give when they give. I heard numbers up to 20, very high numbers. So, we can discuss that. But when we do this, we tend to give certainly below 10 milligrams. And this is I repeated, without changing any sort of geometry, I repeated the same microcatheter injection after a few minutes, I think 5 or 10 minutes after the injection, to try and get material to understand, did we do anything here? And if you look at this image, I'm going to put it side by side next, but now you see that indeed the vessel now is open. Now there is antegrade flow in the central retinal artery. And, if you don't believe it, I put these images side by side. And here it is before intraarterial TPA, and this is after intraarterial TPA. And now when you see here, obviously there has been a change. No doubt about it. The vessel reopened. Now, how this was associated clinically with an improvement? Actually, it was associated with an improvement, not like a dramatic improvement, but with improvement, and this ended up being like the exam later on with with certainly vision loss, but the patient can sort of like count fingers. So I would say the messages here, and this is the last slide. Few things. First, the understanding that choroid blush doesn't mean presence of choroid blush doesn't mean that the central retinal artery is occluded. Something which is an anatomical message that it's pretty obvious when you study this anatomy, but it's always good to go back, because one of the surrogate that is used to say preserve vision is this choroid blush, not necessarily. Okay. Second, like CRAO, like TPA, intraarterial TPA, yes or no? A lot of questions, lots of uncertainty, lots of questions. But in my mind, when we had all this question about like, intracranial thrombectomy in the early 2010, right? One of the main lessons that we got is that we want to see the occlusion on a CTA, like as part of the decision to go ahead, yes or no, right? And that was like one of the important switch, together with the technological improvement with stent retriever and so forth. But one of the most important things to make the trial positive was, okay, we're going to include the patient in which the CTA shows the occlusion, right? And that was an obvious important thing in the improvement of our understanding of stroke, thrombectomy, and so forth. Could it be the same here? Now we're at a stage where imaging can prove things at this level. So could it be that now these are the patients which we should take? The one in which, with a very, very well detailed imaging analysis, can we prove the occlusion of the central retinal artery? Now, another thing I want to say is that we've been doing this quite a few times, right? Like in this patient with CRAO, doing as good as imaging as possible, and the experience has not been that great. I'm showing this case really as probably the only extremely convincing one. Okay, because together with this, we have a lot of cases in which, I would say a lot of, we're talking about maybe 5 cases or so, in which by applying the same imaging, the same sort of analysis, we were not able to prove the occlusion of the central retinal artery. So, I wanted to remark that limitation as well. Happy to hear comments or opinions.
Beautiful. 2 questions. One is you showed that there was a reconstitution of that artery before, so why would it need to be reopened? Second, second question, do you think, apropos of the DMSO toxicity, how about contrast toxicity in such small artery, in such delicate territories?
Okay, so first question. Again, I wanted to remark that this level of analysis I got to later. Okay, during the case, I acquired the imaging, but I didn't look at them in details. But you can argue it's the same with an M1 occlusion, right? You see reconstitution from the ACA, you don't reopen. Yes, you reopen the vessel, right? And here the patient is suffering, so these collaterals may not be as effective. But whatever, I don't know about that, right? Like we don't have a correlate of a perfusion imaging. The clinical exams here are what we're using as a decision metric, right? Your question about contrast toxicity, the amount of contrast injected in the I would argue that with a normal angiogram we inject much more contrast into the ophthalmic artery than the amount that I injected with a microcatheter here. Right. So is it like maybe the pressure is higher and can cause problem? I don't know. But, in this particular case or other cases in which we injected contrast in the ophthalmic artery directly, I do not recall having a worsening or some new problems just because of that. Is there there are some comments or
Yeah, there's some comments like basically about, I mean, the logistics, like obviously if we need GA to even like understand, like your message is that basically people that come that are billed as CREO may or may not have CREO. That's been our experience, or at least our imaging. When we go to thrombectomy, we go based on imaging. Here we go based on an exam that seems to not always be consistent with what we think the imaging should look like. So it's more of a mixed bag. The problem with the CREO, I guess the big message is it's kind of a mixed bag. We're not really sure if we're selecting the patients right for the treat for thrombolysis. And yes, without anesthesia, it's impossible to see these tiny little vessels. And I'm also curious about like people with acute hearing loss, right? That's another problem. Most of them are viral, but some end up with like an ischemic pathology somewhere in the inner ear. We don't have a way of, how do we select those? And it's a very disabling symptom. Not so much hearing loss is disabling enough, but one side hearing loss, okay. The tinnitus that sometimes comes with that as part of the hearing loss can be like horrible. So just limitations of small vessels supplying extremely important organs.
Eytan, did you give heparin on top of the TNK when you were doing this?
No, I didn't. We don't give unless I actually forgot if I went radial or not. If I went radial, yes, 2000 as usual. Otherwise, we don't give heparin.
Yeah, I just asked you honestly because you're in such a, I guess uncharted territory with a small microcatheter and a small artery. I applaud you for the imaging, it's beautiful. I agree. I don't know what the right answer is. We'll always get a handful of these consults from the ER every, whatever, over the course of several months. And I think our discussion is very similar to what you had just mentioned. We all mentioned the Eagle trial. We all mentioned the lack of evidence. I would say for the most part, the choice is not to intervene, to be honest. But I don't know what the, I don't think.
I actually didn't want to intervene. The patient was,
No.
I didn't want.
I don't know. Did you, just to go back to the dosage selection, were you, deciding between how did you come to 4.5?
I think I forgot exactly how, but I wanted to stay low, like, and specifically because we already gave TNK IV, and somehow I don't know how 4.5.
Yeah.
I forgot that, but maybe someone said 9, and I said I'll go with half of that.
And you just bolused it, or you just
slowly through the microcatheter, yeah.
In the cath flow, vials come with 2 milligrams. That's for me, it's like 4 milligrams, 2 vials. There's no data. But I think if you go by how much you're giving in terms of concentration, like for the tissue that you're giving, like 4 milligrams into the eye versus like a full dose to the body, like it's a lot, right? Like it's a lot to this amount of whatever it is, eye, muscle, whatever. Has anyone, I have not heard of, has anyone heard of like hemorrhagic transformations or any hemorrhagic complications in the eye from TPA injection? I haven't really, like we're careful to exclude a hemorrhage. One of the issues with this condition is, right, people come, you have to quickly they want to decide something, but you have to have an exam, make sure it's not like a detachment or some other thing.
What is the literature on hemorrhagic or orbital hemorrhagic complications from like IA therapy for retinoblastoma? Does anyone know what are the?
But they
Oh, yeah.
don't do TPA with that.
No, not TPA, but any, I mean, any, you know, any angiographic complications, hemorrhage, dissection, et cetera, et cetera.
Don't know.
Yeah, we don't really, that's one thing we don't do. So I'm not sure.
Liani says, if you're not able to catheterize the ophthalmic, have you done ICA inject? You know, I have not done it, but, you know, I would say, can you essentially, she's saying, can you just inflate a balloon in the ICA and inject from below? I guess that's that would be a solution. You know, I would say, though, you know, given the uncertain territory that we're dealing with, like, safety is extremely paramount, right? So you know, anything that where you can see the risk is a little more than your minimum, I would avoid.
Okay, well, I think, again, we've overstayed our time by over an hour this time, which is great. It is, you know, it's going to be like this. Thank you to everyone for coming and attending and commenting. Thanks. Great to see everyone, and thank you for presenting. Please spread the word. I don't know when the next one will be. Well, it'll be on the website. We'll put this one on YouTube as we do always. And if you have more cases or anyone, you know, what to show, please go ahead. Thank you so much.
Thank you. Thank you. Bye-bye.
Bye, everyone. Bye.
Bye.
Thanks,
Thank
guys.
you. Bye-bye. Thank you.